Welcome and thanks for viewing this recorded panel discussion brought to you by the Suicide Prevention Resource Center. My name is Adam Chu and I'll be guiding you through this event. This panel discussion focuses on accreditation standards for suicide prevention in health and behavioral healthcare settings, specifically those from the Commission on Accreditation of Rehabilitation Facilities, or CARF. Before that, I will share a bit about the Suicide Prevention Resource Center, and then we'll move on to the discussion. The Suicide Prevention Resource Center is funded by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. The views, opinions, and content expressed in this product do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, U.S. Department of Health and Human Services, or SAMHSA. The Suicide Prevention Resource Center fulfills its goal of advancing the national strategy for suicide prevention by building capacity and infrastructure for effective suicide prevention across the country through training, consultation, developing resources for a variety of settings from states, tribal communities, health systems. And our goal is to reach individuals across the lifespan. We also foster key partnerships that engage a wide range of stakeholders at the national and local levels. And we also serve as a secretariat for the National Action Alliance for Suicide Prevention. SPRC acknowledges that the land that now makes up the United States of America was the traditional home, hunting ground, training exchange point, and migration route of more than 574 American Indian and Alaska Native federally recognized tribes, and many more tribal nations that are not federally recognized or no longer exist. And you can take a moment to review our land acknowledgement if you wish to do so. I also want a moment to highlight the importance of systems-level focused suicide prevention in healthcare settings. The Zero Suicide Framework is a comprehensive approach that brings together the most effective and data-informed suicide care practices with the goal of standardizing how health systems support people at risk for suicide who are in care. These 7 elements are the core components of the Zero Suicide Framework. When implemented together, they can help ensure that systems are designed so that providers are equipped to provide care and instill hope so that people at risk of suicide are supported in lives worth living. Turning to today's panel discussion, accrediting organizations and associated accreditation standards can also offer guidance and support around zero suicide implementation and systems change. With that, I'm joined by Michael Johnson, Senior Managing Director of Behavioral Health at CARF, who will elaborate on CARF, its suicide prevention standards, and this idea of alignment with zero suicide, and also by Casey Pickert, Behavioral Health Grants Project Director at Hope Network, who will tell us a bit about how engaging with CARF has impacted Hope Network's zero suicide efforts. So Michael, I'll turn it over to you to introduce yourself further as you like. And then Casey, if you could please do the following after him.
It's a pleasure to be here today. So as you said, I'm the Senior Managing Director for Behavioral Health at CARF. What that means primarily in my role is that I am sort of the strategic leader for all of the behavioral health, OTP, related efforts here at CARF, and I am the person who is responsible for the development, writing and then ultimately the implementation of all of our standards in the behavioral health and then the OTP manuals. And I'm kind of the interface, if you will, between regulators, payers, and organizations back into CARF. So thanks so much for the opportunity to be here today.
My name is Casey Pickert, and I'm also really grateful to be here to speak about the important work we've been doing. My role at Hope Network is Behavioral Health Grants Project Director, and we were really grateful again to be awarded a grant from the Substance Abuse and Mental Health Services Administration, also known as SAMHSA, to implement the evidence-based zero suicide model. So my role is really overseeing all of the system-wide changes that are occurring with that around training, policy procedure, workflow development, as well as ongoing monitoring to improve our processes. Thank you.
So let me take a few minutes, I guess, to talk about CARF and who CARF is, because I'm sure that not everybody that is going to be watching this webinar is aware of exactly who we are. CARF is a not-for-profit accrediting organization, and there are a variety of different accrediting organizations in the healthcare ecosystem. We predominantly are focused on sort of health and human services. And so CARF accredits in the behavioral health space, and we are the largest accreditor of behavioral health organizations in the United States and frankly, the world. We are a global accreditor, and we accredit in about 25 or 26 different countries around the world. And we accredit in other areas aside from just behavioral health. We accredit in medical rehabilitation, so spinal cord injury, brain injury, concussion rehab, stroke rehab, that sort of area. Aging services, so long-term care facilities, adult daycare, dementia care, CCRC kinds of programs and the like. Child and youth services, so similar nexus between both behavioral health in the child and youth space and the child welfare space, which would be looking at shelter care, group homes, foster care, and that sort of stuff, as well as other things that are similar to behavioral health with counseling and residential treatment and things like that. Employment and community services, which is predominantly services that are focused on persons with intellectual disabilities, as well as people who are looking for support employment and employment skills building and things like that, that may be because of either a mental health issue, a brain injury, or intellectual disability. OTP programs, so methadone treatment programs. We are one of 3 accepted accreditors by SAMHSA for the purpose of federal recognition for methadone treatment programs. And vision rehab services, so services that are directed to people with vision loss to help them to live their full and productive lives. So those are the primary areas that CARF accredits in. And when we say, like, what is accreditation? I mean, at its core, what accreditation ultimately is a quality improvement activity. You know, we write standards with input from the field that helps us to develop standards that optimally is looking at what does quality look like within a framework that can be implemented by an organization that ensures quality both on the business practice side as well as the clinical service delivery side. Now, that means that we send in surveyors into an organization to look at a pretty thorough inspection, if you will, survey of all of the business practices and all of the clinical practices and their alignment with those standards. When there are areas that are not aligned, not in conformance with our standards, that's where we're giving the organization feedback about areas that they can get better. Now, one of the hallmarks of CARF is that we have a consultative accreditation approach using peer surveyors, meaning that the surveyors that come into an organization that are doing that work are folks who work in CARF accredited organizations. Now, obviously, they've been trained and have developed expertise in being able to share their information and feedback to organizations. But we view that as people who are sort of concurrently solving some of the same problems that your organization might be solving, is where we think there's real value in helping to bring all of the organizations up in terms of overall quality, to try to improve the services that individuals are receiving. And our goal and our mission ultimately is to really ensure and enhance the lives of the individuals that are being served in CARF accredited organizations. We think there's a number of benefits in being accredited by CARF. They could be things like in ensuring service excellence, you know, that comparing how you're doing to the outside world and looking at an external rather than an internal benchmark. It creates accountability for the organization to payers, to regulators, and then ultimately to the persons that are being served in that organization, saying that we are willing to go out and get that feedback as a way to ensure that we're doing the best job possible. There is going to be business improvements. You know, a lot of times we think about in the way that the healthcare ecosystem operates, there is an awful lot of emphasis that is rightfully paid on the quality of a particular service that's being paid for by either an insurance company, a state, Medicaid, something like that. But It's also important that the business practices of the organization are of high quality and are ultimately sustainable, in order to ensure that that organization can continue to meet its mission to provide the care that it provides in its community. They need to have solid and sound business practices. And that's one of the things that being an accredited organization helps you to get that feedback and to be able to strengthen, not just focused on clinical practice, but your overall business practices as an organization. It reduces risks for organizations because we are going to, through the implementation of a quality framework that's being measured and managed by you, you're going to ensure that bad things are less likely to happen to your organization if you're accredited. And in fact, many organizations that are accredited enjoy lower workers' comp premiums because those insurance carriers know that you are implementing certain practices, which will translate into lower risk exposures for them. And they often pass that break on to the organization itself. And then, of course, there's the opportunity for networking. Other CARF accredited organizations, you can kind of become friends, with each of those organizations as a way to share resources, share information, and be able to talk about how you are able to demonstrate conformance. And even the peer surveyors that are coming in, oftentimes there are relationships that are struck up in terms of being helpful even after the survey itself ends. So that's kind of a little bit about the background of CARF. And I'd like to transition now to talk about some of our standards and what we've implemented over the past several years, trying to align with the principles of zero suicide. I'll say that we've done that in a couple of different ways. One is through what I'll say process standards and then program standards, which I'm going to talk about a little bit later. So in terms of process, we've tried to install actions that we know that organizations should do that are aligned with zero suicide principles without being called out as being that. So one of the first things that we did is in the program service and structure area of our standards, which is kind of the clinical administration standards. So in the core competencies that are required for each direct service person is going to be an emphasis on the identification of clinical risk factors that include suicide, violence, other risky behaviors, as well as safety planning. So that means that on an ongoing basis, each year, there should be investment in terms of both training and a competency assessment for individual clinical staff to ensure that they are maintaining the expected level of competency in each of those domains. Additionally, in the ongoing supervision of all clinical direct service personnel, we have an element that there should be ongoing supervision around risk factors for suicide and other dangerous behaviors. What that means is that one of the areas of focus on perhaps an annual basis, let's say, as part of the organization strategy for how it conducts clinical supervision, it should ensure that an area of focus during that period should at least be around suicide, competency around suicide, risk assessment in terms of safety planning competencies, things of that nature. Then in the area of screening and access to services, a few years ago, we required all organizations that are accredited by us use a standardized tool for screening. Now, we know that obviously many organizations, as a part of their assessment process, might have had as a part of the biopsychosocial history some questions around perhaps history of suicide, any suicidal thoughts, but that is not as effective as implementing a standardized tool. Most often the Columbia, other tools could be used as well as safety or anything else that may be validated and reliable for the population that's being served. But each individual that is being admitted into a program needs to have that screening tool done. And then when the assessment is being conducted, then there should be elements in the assessment based on the screening tool that is maybe digging a little bit deeper into reasons for perhaps some of the risks that are presented and some of the history gathering and trying to utilize that as a part of the development of the overall treatment plan to ensure that an individual and their history around maybe their mental illness, maybe their depression, anxiety, if there are risks that they are engaging, not necessarily exclusively in suicidal behavior, but other self-injurious or high-risk behaviors are being addressed as a part of the individualized treatment planning process for the individual. Next, in our treatment planning section, we have connected to the suicide risk screening that if an individual has risk factors for suicide, violence, or other risky behaviors, then an organization is required to implement a safety plan. The organization needs to establish a written protocol that decides when and under what conditions a safety plan is done, but it should be related to the risk screening that is done as a part of the initial assessment process. And our safety plan requirements are pretty much aligned with what you would expect a Stanley Brown safety plan template or other similar template would be acceptable. But there are several elements that the safety plan needs to include. The next process-oriented standard that we've implemented is that in the transition and discharge process, we have a standard that reads that the program implements procedures for referral and transfers to ensure the process is effectively completed. Now, that's kind of a vague standard in a way, but the purpose of that is recognizing that at the transition points, the care transitions that happen, now certainly we always think about it in terms of coming out of a hospital, inpatient, or a crisis stabilization unit as being a really high risk time, but really any of the care transitions from any level of care, whether it's a higher to lower or just even a more lateral care transition, a lot of times people fall through the cracks. And if they're not really ready to be transferred to discharge, but really that there was an intent to continue care, organizations have an obligation to ensure that the processes that they use for managing those care transitions are effective. It's not been uncommon in the past that a lot of times people would hand a referral sheet to an individual and direct them, and once that person left, they never felt any further obligation because they felt like they've made the transition by simply handing them a referral document. And we're saying that the organization needs to be aware of like how often do people actually make it into that next level of care, or and if they not, do they have a way of going back and reaching back out to the individual to ensure that they can be re-engaged in care, or some method to ensure that they're able to actually make it into ongoing care as is prescribed. We also have, for programs that are being in crisis stabilization units, we do have that they have a sort of a little higher bar of obligation to ensure that they're effectively transitioning people into the next program post-discharge. Now, we have a couple of programs that are not just those process-oriented things, but are actually programs that are designed to support people who are at risk for suicide or maybe have a strong history. We accredit a number of crisis programs. We accredit crisis contact centers, which could be, call, chat, sort of the 988 construct. We have accreditation for that and then have accredited many of these programs for many, many years prior to the 988 rollout. We also accredit crisis intervention programs, and those crisis intervention programs are often inclusive of mobile crisis services. And we also accredit crisis stabilization programs. And all of the crisis programs are viewed as being part of a continuum, right? That they aren't sort of exclusively standalone, that they oftentimes work together with one another. And so there are some shared standards that all of the crisis programs need to meet. And then there are specialized standards based on the particular type of crisis services that's being offered. So all crisis programs have to demonstrate the capability to make appropriate clinical decisions based on the expertise of the staff, ensures that people are placed in the least intrusive or least intensive care that is going to safely meet the needs of the person. All crisis programs need to maintain accurate and current resource lists for community resources that would be needed for people to be engaged with prior to completion of the crisis-based service. Whenever dispatching is being managed by a program around mobile crisis, that they are clear on who has what responsibilities, and those responsibilities and whether or not first responders are engaged in that are going to be managed with a bias towards not having first responders engaged unless it's necessary. And then, of course, we want there to be meaningful programmatic responses to the well-being of individual staff. Working in a crisis-based program can be very stressful and can be very taxing on an individual. And so we want to make sure that those programs are both aware of the well-being needs of the staff and that they're doing things to respond to that and ensure that ongoing well-being. So the last program that we have that's not a process orientation, but a program orientation is our comprehensive suicide prevention program. We wrote standards for this, I'm going to say probably 7 or 8 years ago, to develop a standalone program for those prevention types of programs that are focused exclusively on reducing the incidence of suicide in a particular population. And so it's really a comprehensive approach towards prevention of suicide using, evidence-informed practices and activities, ensuring that stakeholders are invested and involved in the design and capacity building activities for the particular program. There's training that's required for personnel, and again, similar to in the crisis space, that there are supports for staff when a suicide event occurs. And I know that that is a program that Casey's organization has accredited, and I'm sure that that's something that we're going to talk a little bit more about as we go further in the webinar today. So I'll sort of stop here and transition back to Adam.
Great, thanks very much, Michael, for the overview on the CARF standards, both process and programmatic. I want to shift gears here and turn this into a bit more of a discussion, maybe raise some points that you touched upon in the overview of the CARF standards. And also now we're going to hear a bit from Casey too, in terms of that on the ground zero suicide implementation, plus sort of leveraging the comprehensive suicide prevention program and the work at Hope Network. So Michael, to start the sort of panel discussion part of this, I wanted to ask, when this comprehensive suicide prevention program was developed, was there an intersection with the zero suicide framework? Earlier you said it was 7-8 years ago. Did one inform the other? I mean, I guess I'm kind of asking, like, why did it come to be? How did you do it? What was the process like? And what spurred CARF to go down this road? Yeah,
thanks, Adam. So it's funny, the question that you're asking about, like, did the zero suicide inform? It sort of did indirectly. And the reason that it did was because one of the ways that CARF develops standards is that we pull together experts and an expert panel whenever we're going to write standards. We don't just sit and write them on our own. And so Julie Goldstein Grummett was one of the people who was involved with on the panel for writing those. So she brought all of her expertise from zero suicide and the EDC with her as a part of that group. But really, we were reached out to by the Department of Defense. So the person who was in charge of the Defense Suicide Prevention Office at the time was familiar with CARF, and we do some accrediting of some active DoD programs, and so was asked if we would be interested in doing that. So CARF had been one of the initial founding members in the Action Alliance for Suicide Prevention, so we had some involvement in that space, but this was an opportunity for us to perhaps increase and improve that. So we jumped on that opportunity to write those standards, and we felt really good that we would be adding to the space by not just implementing something around these particular processes that all healthcare providers should do, but actually having the opportunity for specialization that I think could create some additional synergy in an organization if they were to implement that program as well as the process activities.
Thanks, Michael. Yeah, and I think earlier you sort of described all these alignment points and the standards in general, the process standards, and then this programmatic piece with the zero suicide framework. And I was going to ask how the program matches onto the zero suicide framework in terms of common features, but it feels kind of like, given the process that was put into place to develop them, it sort of aligns in every point that you could think of, including taking care of the people who are caring for those at risk, which sometimes gets flown over in some ways. Would that be accurate? Is there anything else you sort of wanted to point out? Like, we really wanted to make sure that this was a common feature among both the framework and the program that was being put together.
Yeah, I mean, that was always our goal, right? And mostly because, I like to joke sometimes I'm a recovering clinician myself. And so I've been in this field for many, many years. And I had been trained, or perhaps I should say poorly trained, in some of the ways that we would conceptualize the treatments of suicide, back in the olden days, let's say. And so as I got more familiar with and got more involved with zero suicide concepts, I wanted to make sure that our standards aligned on all of the things that we actually could perhaps implement through our standards to encourage organizations to, even if they weren't embarking on a full-blown zero suicide project like Casey's organization, that they at least had those components built into their practices, and so they were doing it even if they weren't as aware that that was the reason why they were doing it.
I think that makes sense. There's a sense of, don't make it feel so new. There's a reason to make some things feel new, but if you can kind of attach it to kind of some common factors or areas of process improvement or interest, I think that's things that we've talked about with people implementing zero suicide too. Is like, what else can you attach this initiative to that sort of makes organic sense within an organization? Well, Casey, I want to turn it to you next. I wanted to know, we heard a bit about origin story in some ways about the comprehensive suicide prevention program, but for Hope Network, when your introduction, you mentioned zero suicide grant, been working in the zero suicide space before that. So what was kind of going on at Hope Network in zero suicide, or maybe just suicide prevention overall, when you decided to pursue this comprehensive suicide prevention program or any of those CARF process standards overall?
Yeah, thank you, Adam. So I think it's really important to understand contextually a little bit about how Hope Network works. So we have over 200 different locations across the state of Michigan, and we offer a wide array of services from outpatient to residential homes, kind of those adult foster care homes, crisis residential, and many others. So we are a large, very complex organization, and certainly anyone can be impacted by suicide. So this is really a big big initiative to tackle, but it is very, very important. And so in the fall of 2019, Hope Network expanded our leadership to include an office of the chief medical officer. And so with that director oversaw zero suicide, the implementation at a previous organization. So coming into Hope Network, having that experience, finding various funding opportunities to be able to support this work and get it off the ground. Because quite frankly, there wasn't a dedicated team able to focus on this. Of course, our workforce members are, doing our best to keep everyone safe and having that safety component, but we know how important this is to have a dedicated team dedicated towards that early prevention. What do we do when a crisis occurs? So we really had, those ongoing monitoring checks, very limited training. But at this point, looking at that funding opportunity and being awarded that in the spring of 2021 and really having a dedicated team to roll out these best practices.
That's great. Appreciate the context, and that's a lot of organizations to implement in. And I think, certainly the funding supports help kind of push things forward. So I'm curious about, at that point, I guess at what point in that timeline did the CARF standards come into play? Was it after that person, came into that leadership position? Or were you already in this space with suicide prevention work anyways? And then looked at the programmatic standards here and chose to align with them at that point. And what does that look like thus far?
Yeah, thanks for clarifying that. So Hope Network was awarded a 5-year SAMHSA grant to implement the evidence-based zero suicide model in March of 2021. It just so happened that our organization was going through our next CARF survey and accreditation in July of 2021. So very much, as Michael spoke about, the kind of competencies and procedures very much align with the zero suicide model. And so we figured, why not go forward and apply for the comprehensive suicide prevention program through CARF, since we're already really starting to begin to formalize and be really intentional about this work.
It seemed like the timing really was well suited to pursue, two things at the same time. What is the term, like feed two birds with one piece of bread, to use the more positive spin on that analogy? I wonder about, thinking about that timing and kind of trying to stand up a grant and do this at the same time. That's a lot. Having seen how some of the grant work is done. I wonder what kind of support, and Michael, you sort of alluded to this too, in terms of just the surveys, our peers, but what kind of supports were provided on the CARF side in terms of, guiding you through doing that at the same time as, having a grant? Just purely from, I think more of I guess that's like a workload question, but I'm more curious about, if another organization goes down this road, what kind of supports are there? What kind of interaction is there? And this can be, Casey or Michael, in terms of what you've observed, and then Casey, what you've experienced. So either one of you can go tackle that first.
Well, I'll maybe say it from our point of view, and then I'd be curious to hear what Casey says. But I think that the thing that I would imagine that Hope Network experienced when they looked at the standards was that it provided a framework for them to be able to organize their work, right? So they have this grant, they're implementing an activity, and then here comes this framework where, you're actually going to do like a pretty in-depth analysis of, your environment and what do you need and what's the incidence of suicide in your population. How are you going, what activities are you going to implement? How are you intending to measure, what your impact is? And so that framework probably allows you to have a very logical approach to how you would implement. Now, we, of course, are always going to answer questions for an organization, but it really is up to the organization to figure out how it's going to demonstrate conformance to the standards. And so, although that was there, then I imagine that when Hope Network picked up the standards and went, okay, there was probably some things that you already knew right away, but there probably were some things that were, we got to think about how do we actually address that, if that's right, Casey.
Yeah, I think you're pretty spot on there, Michael. And so certainly the guidelines provided our teams a really nice framework to identify, maybe we're already doing some of this. Where are our gaps? Where are some areas of improvement? And so, in addition to that, really utilizing a workforce survey through the Zero Suicide Institute to identify, what exactly, one of the protocols is, that standardized screening for suicide risk. So, asking our teams questions on what tool are you utilizing, and we had around 20 different tools, some I've never even heard of, and so really providing that standardization, that framework around all of these different components was really helpful, as well as getting any of our questions asked around our interpretation of what maybe a standard might mean for our organization, but still having that flexibility to be able to adjust that. As I mentioned, we do have a wide array of program offerings.
I mean, it really sounds like, well, two things. One, there's this element of quality improvement from that perspective among the suicide prevention program, and that's no accident. I think going through that lens begets asking some of the same questions of an organization that you would ask as a part of zero suicide implementation anyways. And to be able to answer those, you go back to some of those clinical, operational, administrative components that you kind of need to work through as you get implementation started to know the answer to some of the questions that would help you assess your performance against some of these standards. So I think that's a really interesting kind of synergy that's in place. And, a lot of that I would imagine is born out of, part of the development of those standards, which I think is a really interesting through line. I think from both of your perspectives, you both sort of alluded to things that, yeah, we probably are doing pretty well here, and things that, well, we probably want to shore them up. I guess we'll start with Michael first. Like, outside of Hope Network, do you have observations to share in terms of common stick points that people are finding themselves in terms of if they're going down this the comprehensive suicide prevention program road, what's the thing that probably people are going to hit a snag on?
I'll say this, Adam. I don't think that organizations probably struggle with it if they've made the decision that they're going to implement this. The issue has been that many organizations have not implemented it, even when I think that they have program offices within their organization that is designed, towards, say, let's implementing a zero suicide methodology. One of the things that, I feel like there's an opportunity is, again, we've put in the standards in all organizations, these process activities that are aligned with zero suicide concepts. But the thing that's missing is what happened then, right? What was the outcome? And anytime an organization is having to get a particular program area accredited, one of the things that they have to do is they have to measure their outcomes, right? What happened? And I think that that's where there's a real opportunity for organizations when you have, let's say in whether it's at Centerstone or whether it's at Hope Network or any of these other larger organizations that have, a real focus on implementation of zero suicide concepts that are universal. This really structures the activities in such a way to ensure that we have outcomes and we have performance metrics that we're measuring in that quality framework that are exclusively focused on attacking those activities and ensuring those processes that are in place outside of just the standards pieces. But, what really happened? How often were we getting people connected to community resources? What kind of satisfaction did we have from people around these types of activities? Was there a measurable difference in the outcomes that happen in terms of perhaps not just suicides, but it could be attempts, or it could be a reduction in overall risks according to ongoing scale measures and things like that. So I think that becomes the focus that the Comprehensive Suicide Prevention Program affords an organization, is to create that framework to measure that exclusively, and how effectively are they implementing the activities that are supporting all of those efforts.
Yeah, it sounds like to some degree, like I think we hear and still know that improve element to be one that is quite challenging. And this is like another reason, another motivator to be more focused on that, or focus on that for a different reason other than the framework itself says so. This is a little bit more of an external motivating factor, perhaps, which I think is great for the notion of sort of like show me the incentive and show you the practice change and thinking. But Casey, I wonder about your reflection on that as well, and how maybe that lens has landed in Hope Network, and has it made it more robust in terms of the measurement in terms of pursuing this standard, or any other comments you might have about either stick points or facilitating factors, really.
Yeah, so certainly it's really important we are measuring everything we're doing, right? We need to be able to tell the story and demonstrate what outcomes, that we are implementing with this important work. I think it's really important, and a piece I'd like to touch upon is our messaging around this within the organization, how we're talking about suicide, because that was a really big sticking point. It still is. This is a very long journey. As I mentioned, we're really about 3 years in of doing this intentional work. our funding for this grant is going to go away in 2 years, but that doesn't mean this work is going to stop. We are really operationalizing all of this and really being a safer, suicide care culture across our organization. And what I mean by that is, as Michael alluded to earlier, the clinicians and their training, I think there's a lot of improvements that need to be done there, and also a shift of getting away from kind of that blame and shame culture if an incident does occur. And so we've really kind of taken a step back in how are we talking about this in our organization, and not just the clinicians, everyone. We all play a role in suicide prevention. So a big piece of that is around the training, the education, and the ongoing education. On day one of our new hire orientation, myself or one of my teammates, we go in there, we meet we meet everyone, we talk about zero suicide. What does this mean? What are you going to be learning about, and what does this mean within your role at Hope Network? We have to continue to talk about that and shape that message in order for to give our team members the tools and skills to be able to feel comfortable and empowered to ask the question, and not only for the people that we serve, but also for each other as teammates. Again, we got to make sure that each of us are doing okay. And so that has really helped us a lot with getting more support around implementing zero suicide. And with that support, kind of with that buy-in of, this is really important. We're not just asking our team members to do additional work, additional screenings and assessments. We really had to take a step back and remember our why, and communicating that why and ongoing is so critical and important to this work. And again, to save as many lives as possible, which is our goal.
Thanks very much, Casey. I think the can't pour from an empty cup component of the zero suicide framework and the comprehensive program, frankly, right, I think is what we're seeing here is really important. So Michael, I had a question for you. I wanted to come back to something you raised earlier in the recording, where you highlighted that there's this consultative accreditation approach where the surveyors are peers. They work in CARF accredited organizations. Maybe they've experience going through issues the same that they might find in the organization that they're surveying that given day. Have you got any feedback about whether that's positive, negative, it's felt more collaborative, whether from the organization being surveyed or the surveyors themselves?
Well, I mean, it's always been a positive, right? Because it's fundamental to our accreditation process that's been in place for nearly 60 years now. So it really is part of who we are. But the role of the surveyor is twofold. One is to apply the standards in the context of the organization to determine whether or not the organization is in fact in conformance with the standards. And so that part is its own challenge, because not everybody does everything the same way, right? So we try to write standards that are non-prescriptive, that are flexible based on the context of a different organization. But really the value is that, because to your point, Adam, that you're asking, is that, if they have come across similar challenges. So as Casey was talking about, like how communication is so important and that everybody being on the same page, a surveyor could certainly come in and say, well, this is how we do it in my organization. This is how we've attempted to try to manage some of these communications. And sometimes those little brief nuggets can be of real value. But I will tell you, before I came to work for CARF full time, I was a surveyor for CARF for about 17 years. And I will tell you that as much value as I think that I might have brought to organizations, I got way more back. And so I might have gone to a place like Hope Network and seen things that they were doing way better than perhaps the organization that I worked in. And I was taking that stuff back to my organization and saying, hey, I just saw something being done this way. It was really, really good. We ought to try to do that. And to me, that's where, as opposed to having an inspective sort of mentality, that's where the real value of our accreditation approach is that it kind of germinates those ideas in other organizations, and there wouldn't have been a normal pathway ordinarily for that information to be shared. So I think there's a real benefit to multiple stakeholders in this process, the methodology that we use for our survey process.
So Casey, I wanted to turn back to you and just ask, is there anything you would do differently if you were starting over or going back in time a little bit with the zero suicide implementation?
So, with any initiative, it's like you look back and at all the different lessons learned. But I don't know if I would change anything specifically, because with everything that we've been rolling out and training and all following all the evidence-based practices, we've learned, so much. And so I'll just tell you, in my role as a project director, you know, getting hired right in, I developed a whole plan with all of our action items and timelines and deadlines. And that kind of went out the window. So I guess my point is you can only plan so much with this, and really just having all of the right voices at the table, I think, is so important. We can't do this work alone. And so, moving forward, this year, at the end of this year, we are going to be going through reaccreditation with CARF. And so we are planning to move forward again and getting the suicide prevention comprehensive program standards again. That's really our goal. There's a really lot of awesome work that's been happening since we were accredited a few years ago. And so again, as I mentioned, when we kind of dove right into this work, really wanting to get this accreditation as well as meeting the grant goals and initiatives, we put the various tools into our EHR system. But now we're really in the final stages of developing a much more comprehensive pathway. So it's really this suicide care pathway, which there's an enrollment phase, continuation, disenrollment, and specifically, as Michael touched upon, giving the whole care team these tools to be able to really treat and assess that suicidality, specifically with the collaborative safety plan, with the risk assessment, having a tab at the top that's the color blue for anyone that is identified at risk, so the whole care team can be involved in this. We're even going to give each individual a suicide care pathway educational sheet, so they know, what does this mean? Why am I maybe going to have more appointments or have this specific intervention? What is a safety plan? And so having a lot more of that comprehensive information for our whole care team, and that as well is going to enhance all the information that we are able to collect for that really important improved pillar, so we can identify what's working well, identify those gaps, re-education, and really again incorporate that all into that safe and just culture around suicide prevention. So it's a couple of the areas where we're headed next. And again, looking forward to our getting hopefully reaccredited with that this upcoming year.
Okay, so that's just so awesome. And I think that level of EHR integration, like that's a ton of work to make that happen, from what I understand. And that notion of sort of everyone knowing what to do when and for which clients, it's just so important. And that takes just a lot of time and consensus building, and just a credit to Hope Network and you for leading out on that. And so thank you for sharing what's coming next. And I just really appreciate too, you're saying, well, I wouldn't do anything differently. We sort of like learn from the things that we did, and here's what we're doing now, which I think is a really awesome approach. Michael, I want to turn it to you now and just see if you had any parting words of advice or maybe nudges for people who might be interested in thinking about CARF accreditation, maybe look closer at the standards, probably lines up well with what they've been doing, or any other, additional thoughts you might have here.
Yeah, I appreciate that, Adam. I guess the nudge that I would have is that, Casey gave an example of kind of the serendipity of, hey, we're working on this project where we're implementing, the zero suicide framework. And it turns out that in the standards manual, they have this program that kind of aligns with what it is that we're doing. And so they made that choice to add that program. I think that there are a lot of organizations that are probably implementing this framework, and they may only have a person or even a part-time person, if you will, who is responsible for managing that project. That doesn't mean that that you don't have enough resources to be able to implement that program for accreditation. And I think that the really important part is that you can do all of the work that you are doing. Having the program accredited creates, I'll say, a discipline and accountability to a process, where you're having to show externally what those results look like. And I think that it gives you internally the nudge to maintain that discipline to the process and to maintain an internal focus. At Hope Network, they can always say internally, we're accredited for this program where we are ensuring that we are implementing this zero suicide framework. And I think that gives it a little bit of gravitas internally as well as externally. And so I would encourage organizations who want to take, maybe supercharge their zero suicide framework activities internally and take it up a notch. This is an opportunity probably to help. And it's not really, I mean, I'm saying it because I think that it would be helpful. It's not like that is going to be, some big cost and driver for an organization or something like that, because it doesn't necessarily add any more real time on your survey team. So it really isn't something that is going to, there's the only reason not to do it is that maybe someone's not making you do it. And that may feel like, well, if we don't have to do it. But I really think that you can probably get real value internally by being able to have that discipline to a practice and accountability.
Well, that's great. Thanks, Michael, for drawing some connections there and help people kind of think things through a bit. Well, with that said, I just wanted to say thank you so much, Casey. Thank you so much, Michael, for the discussion here and sharing your experience, expertise, and perspectives. Thank you again for joining, and you can find out more again by visiting zerosuicide.edc.org and also join the Zero Suicide listserv at go.edc.org/ZS-listserv. You can find out more about the Zero Suicide Framework, including specific resources related to accreditation, which is where you'll probably be finding this recording, by visiting zerosuicide.edc.org. Thanks again for joining.